Shelby, thank you so much for having me. I'm so excited to speak to your audience today about prostate cancer, erectile dysfunction, and some urinary incontinence post-treatment. As Shelby said, I'm a urologist and sexual health specialist in the DC area. I start with this. These are my three wonderful kids. You thought you'd be talking about prostate cancer, and yet I'm torturing you with this. But I put this out there because look how nice they look. They're all dressed up, they're all smiling, they're all looking at the camera. This is what you see from the outside. But looks can be very deceiving. This is what we really look like. I bring this up because after prostate cancer treatment, everything really looks the same on the outside. Sure, you may have some surgical scars, you may have some skin changes post-radiation, but what really changes is the internal aspect, and that's what we're here to talk about today. So just remember, looks can be deceiving, and we've got to go inside. Not that these aren't things that you all know, but prostate cancer is, the second most common cancer in men after skin cancer. There's an estimated almost 250,000 cases a year with a reported over 30,000 deaths annually. About 1 in 6 to 1 in 8 men are affected. And again, the average age of diagnosis is in the 60s. Now, treatment options have advanced, over the last 30 years, one encompassing watchful waiting, which we're not going to focus too much on today. Well, we're going to focus on the after effects of the two most common types of therapy for low-grade prostate cancer, which are radiation therapy, whether it's brachytherapy or IMRT, and prostatectomy. So about 60,000 men per year choose some form of radiation therapy, and 90,000 men will choose prostatectomy. Now, our focus again is going to be on what happens post-treatment. So post-treatment, unfortunately, men start to face the fact that erectile dysfunction occurs in upwards, again, depending on what the data shows, of almost 80% of men post even nerve-sparing radical prostatectomy. What is erectile dysfunction? Well, it's pretty obvious: the inability to obtain or maintain an erection. Other thing we'll talk about are urinary changes, and that can vary depending on treatment modality. In the radiation setting, we see a lot of frequency and urgency. In the post-prostatectomy setting, it's more of an incontinence or potentially change in strain based on surgical healing. So post-treatment dysfunction. Why do we get erectile dysfunction post-treatment, and why is it so difficult to give patients a good statistic as to what their likelihood of preservation of erectile function is post-surgery? And a lot of that, depends on where we started out. So most guys who go in to the urologist for prostate cancer treatment will also have to fill out one of these sexual health questionnaires. Now, this helps us from a research standpoint, but it also helps us to know where your baseline is, because baseline is important. There are general risk factors for, I'm going to go back one more, sorry. There are general risk factors for erectile dysfunction that are not unique to the post-prostate cancer patient. And those include diabetes, obesity, alcohol, smoking, kidney disease, cardiovascular disease, neurologic disease. So it is crucial to evaluate these factors in a patient before talking about what potential outcomes are post-treatment. So just to give you some general information about erectile dysfunction in the population, men with hyperlipidemia carry almost 50% chance of also having erectile dysfunction. In diabetics, they have a 3-fold increased risk of ED than those patients without. And again, none of these are unique to prostate cancer. So I say that yes, you may have erectile dysfunction post-treatment, but you're not alone. So your counterparts that unfortunately, counterparts who've not gone through prostate cancer and the diagnosis that goes along with that and treatment still may be able to relate to your story in terms of difficulty with erections. Now, lower urinary tract symptoms, again, so prevalent in men, they carry almost a 60 to 70% chance of also having associated erectile dysfunction. So again, you're not alone. It does depend on where your erectile function is going into treatment as well. So not to belabor too much about erections, but I do think it's important to have some understanding of what what pathways are involved in erectile function. So just at rest, actually, the penis, the blood vessels within the penis are slightly constricted to limit blood flow. So in the flaccid state, you have this smooth muscle contraction. Again, that's limiting blood flow to the penis and, creating a soft state. There are a lot of things that I'll kind of gloss over, not to, bore you too much with the pathophysiology of erections, but I do want to highlight, some of the factors because that will help us better understand what our treatment options are. All right. I apologize. PowerPoint slide movement is maybe not my best course of action. So what's involved in erections? We talked about, well, we'll talk a little bit about blood vessels, but nerve pathways. So nerve involvement is important. And this comes into play, obviously, in a treatment standpoint, surgically, when nerves are moved or quote unquote spared, and in radiation, where nerves may be in between the radiation therapy and the source or the prostate that we're trying to treat. There are different types of neural pathways, and they will result in different types of erection. But again, we're just going to gloss that over and just realize that nerves are a very important part of the sensory aspect of erections. Again, please don't read all of this. It's going to be very boring and a little too detail oriented, but I want to show you through this picture that blood vessels are obviously very important, okay? The main artery that supplies blood of the corpora cavernosa. The corpora cavernosa are these internal erectile bodies, is the pudendal artery. This is a network of vessels lined by smooth muscle, and these are the areas that expand during erection. And again, with an erection, what you get is relaxation of the smooth muscles within the vasculature to create more blood flow to the penis, compress little veins here that normally will carry the blood out. And so not only are you getting this erection, but you're also allowing you're maintaining that erection by closing off essentially the blood that's leaving the penis. Again, a little bit more detail than you want to know about oxygen content and erectile state, but highlighting the fact we've got to have nerves, we've got to have blood vessels, and we've got to focus on the smooth muscle of the blood vessel to help get the blood to the penis. So understanding a little bit more about what's inside, again, I'm a surgeon, I like to operate, and I think anatomy is wildly important, but I hope it will help make sense for you. So this is just a very basic picture of the male genitourinary system. So we all are sure we're talking about the same thing. Bladder here, the prostate, which sits below the bladder, and then the urethra, the tube that drains the urine from the bladder out of the body. Prostate gland functions to provide about 50% of the fluid for your ejaculate. It actually has no major effect on urinary function other than location. And if any of my patients out there are realtors, you'll know the importance of location, location, location. Side view, again, looking at the bladder, the location of the prostate, the pelvic floor musculature, your levator complex. This is very important. This is your primary modality for staying dry or continent in the male. There's a secondary component here, which we'll talk very briefly about, that is affected in a prostatectomy surgery. And again, your corporal bodies internally, which your erectile tissue. A little bit more of a close-up, lovely blood supply. These are the muscles, I'm going to talk a lot about muscles that are important for orgasm and ejaculation, surround the base of the penis. And again, they're all centered in your pelvic floor. Nerves, not that you need to memorize any of this, but highlighting the nerve aspect, because again, these nerves can be damaged during radiation therapy, and the more internal nerves also as well during prostate surgery. So again, we talk about some different therapies and where the nerves are that supply the penis sensory and some of the muscles. Really, here's your anus, the nerves surrounding the anus, or we call the perineum, extending along the shaft. I love this picture. It's an internal representation of the pelvis. This is your prostate gland with all of the numerous blood vessels and nerves associated with it. So if you think about when you're undergoing radiation therapy, how all of this is affected, and during a prostatectomy, when you have even what's called a nerve-sparing prostatectomy, you're still creating a cut here and trying to keep these nerves preserved. But as you can imagine, these nerves are very small. There's a significant network there. And even with the preservation of the sheath containing these nerves, you can have damage with movement. So now we have a little bit of a background. Let's talk about what our treatment options are. So radiation is obviously one of our treatment options. We discussed about 60,000 men per year choose this as an option. Post-radiation erectile dysfunction causes effects secondary to nerve damage, muscular damage, and vascular damage. You get reduction of smooth muscle, you get inflammation, and fibrotic changes secondary to radiation therapy. Post-radiation, within 5 years, the data shows about 50% of men will develop radiation-induced erectile dysfunction. It's obviously a very significant number. You can get damage to the internal pudendal artery, which we discussed, is one of the main arteries supplying the penis. Reduction in motor function, you can get fibrosis. So that's why erections are affected post-radiation. All of those, different components: nerve, muscle, vasculature. And again, not something that everybody tells you. In the post-prostatectomy setting, again, data shows anywhere from 15 to 90% of men will have some form of erectile dysfunction post-surgically. This does include nerve-sparing prostatectomy as well. The data is technically better in terms of erectile function outcomes post-nerve-sparing prostatectomy. But even in the meta-analysis, those studies are difficult to necessarily reproduce because of a lot of the factors we already discussed, the variability of patients going into the procedure and surgical variability. About 85% of men, again, will report some difficulty with erections post-prostatectomy. So what do we do? Okay, so we know our anatomy, we know what our treatment options are, treatment options for prostate cancer. We know the outcomes in terms of, oh my gosh, a vast majority of men, if not, all significant number, are going to have erectile dysfunction. So what do we do in terms of treatment? Now, treatment is not just medical. We need to be mindful of the fact that erections, while there's a significant, especially in this setting, physical component, pathologic component, there is a psychological, cultural, and interpersonal. So it's really important to be able to discuss this with your physician, discuss it with a professional, whether it's a sexual health professional or a mental health professional as well, because this can be very impactful in your recovery process, even in your erectile recovery process. A little humor to mix things up. Penis is the lightest thing in the world. Even a thought can raise it. And you know what? That's how things are presented historically. But in the setting of prostate cancer and prostate cancer treatment, this cannot, patients will really struggle with that. So what are some of our options? Again, sexual therapists, like I mentioned, can be very helpful. Great way to find it is as easy as going online. And then my other slight joke break, this is more for our in-person folks who are probably bored of hearing me talk, and to keep their attention, two broke men broke into a drugstore and stole all the Viagra. Police put out an alert to look out for two hardened criminals. So hope that one gets some good use in your life. But that leads us to Viagra and oral medication. So oral options, we classify as PD-5 inhibitors. The more common, Stendra, Cialis, Levitra, Viagra. As you can imagine, because they all have different names, they're not exactly the same. Most of that has to do with how they cross-react with certain subreceptors. They come in different dosage, and because of that, they can have a little bit of a different side effect profile. When looked at in terms of outcomes and how patients respond to different therapies, thankfully they're all, they're fairly fairly similar in their outcomes, maybe a slightly higher response in the Viagra arm, but all significantly better than placebo. And how do they work? Again, they work by not initiating the erection. So that's one important thing to note, that you have to, have some stimulation, typically manual stimulation, to initiate the erection. And what the PDE5 inhibitors try to do is they try to maintain the erection by not allowing any smooth muscle changes within within the musculature of the blood vessels. So that's what they do. Side effects, that's important to know. Okay, when you're taking this medication, you want to know, oh my gosh, am I going to die from a heart attack? Am I going to go blind? What's going to happen? All right. The most common ones are facial flushing. Why is that? Because you get dilation of other smooth, small vessel smooth muscle fibers, more specifically in the face and the head. Headache, indigestion. Right. So again, all the same pathophysiology, dilation of smooth muscle fibers that it just affect different areas. Muscle fatigue, sometimes a stuffy nose. You won't go blind. You can get a blue hue, but that's not a very common thing. The nice thing about some advances that we've had in generic medication is, PDE5 inhibitors are pretty cheap. So this is great. They're accessible. They're in a lot of post-prostatectomy surgical recovery protocols. I won't go into penile rehab, as there has not been a very well-defined protocol for penile rehab in the post-prostatectomy setting. But again, cost, thankfully, is not as prohibitive as it used to be. So PDE5 inhibitors are great, but what happens when those don't work? Some guys turn to a vacuum erection device. This is just as a photo of what this looks like. It's essentially, hate to say it, like a vacuum hose that you have at your house, but it is controlled to make sure you don't increase the pressure. There's a ring that comes in different varieties that you put on the base to keep the blood inside the penis. Again, can be used in the general population as well as post-prostatectomy patients. Side effects, I'm big, obviously, on talking about side effects and expectations. You can have bruising, pain, difficulty with the device, I would have to say, is the biggest one. It is hard to fit on correctly for a lot of men. So that, that is an option. I'll be honest, it's not the most widely utilized option. Again, another not very widely utilized option is what's called an intraurethral suppository. It's a medication. It's about the size of a grain of rice that you place into the urethra. Medication absorbs through the urethra into the corporal bodies, and again allows for smooth muscle relaxation and erectile function. Now, the one that a lot of men will focus on in the post-prostate cancer treatment therapy for erections are what we call intracavernosal injections, ICI. This is exactly what you would think if it would be. It is medication that's injected, this is a better picture, directly into the penis each time you want to have an erection. These are the more common combinations of alprostadil, papaverine, and phentolamine that are used in different strengths and different ratios to provide the best erection for a specific patient. We usually start at a lower dose just to ensure that we don't create what's called priapism, one of the wonderful side effects, which is an erection that lasts a significant period of time, typically over 4 hours. It can be very painful, and it can cause more erectile damage than good. So this, while it looks awful, can really be nice in that it typically gives a good erection. Now, again, just to highlight the fact, you have to use this injection every time you want to get an erection. Let me just make sure there's nothing else that I wanted to say on that. Side effects. Thankfully, side effects are pretty limited. I included this because this is on kind of the medication profile list of side effects. I would say the biggest side effects are small hematoma at the injection site. If you're injecting in the same site over and over and over again, you can get some fibrosis or scar tissue there, which could result in curvature to the penis. The other one that we do see is a prolonged erection or priapism. That's why sometimes starting at a lower dose is beneficial. But men who take nitrates for cardiac disease and are contraindicated to using PD-5 inhibitors, this is the medication that we give them. So again, medication is localized to the penis, which is why it allows us to give a variety of medications and in a fairly strong dose. Now, when medications fail, so our PD-5 inhibitors fail, let's say you tried the intraurethral suppository and the injection, what do we do? This is a surgical procedure that has about a satisfaction rate of almost 80%. Now that is super high. What it is, though, it is complete replacement of your natural corporal bodies. So if we go back here, these guys here with synthetic cylinders. These cylinders exist within the penis. There is a small pump that gets placed within the scrotum, and then a reservoir of fluid in the lower pelvis. So this is obviously a more extensive surgical procedure. You're putting a significant amount of foreign material into your body that carries a risk of infection and potentially erosion with it, but it does have a very high satisfaction rate. I will speak on it briefly, but you can use this in conjunction with what's called an artificial urinary sphincter for some men who also have stress incontinence post-prostatectomy. Again, risks and complications, infection, system malfunction, glands necrosis, and obviously bleeding when you're talking about a surgical procedure. Now, what's something else that's on the rise? This is something that we do in our office. It is called low intensity shockwave therapy. It's nice being a urologist. We get a breadth of information. Kidney stones are treated by shockwaves, but a shockwave that's focused on a very small area, let's call it, 2 to 3 millimeters. That same shockwave technology, which is FDA approved in other arenas for essentially creating micro trauma, has been utilized in not only urology, but other specialties. Instead of having such a small focal point, this extended focal point allows for different changes at the tissue level, some new signaling pathways, nerve repair, recruitment of kind of quote unquote stem cells. I don't mean stem cells like you're going to regrow something else, but stem cells that are already in our body that differentiate. Let's say you cut yourself, you're going to have regrowth of that skin tissue. So activation of those cells. This is still being studied. It is not currently FDA approved for erectile dysfunction, but a lot of major universities and sexual health centers are utilizing this in treatment. So lots about erectile dysfunction in the post-prostatectomy and post-radiation therapy. But what else can happen? And I mentioned this at the beginning, urinary changes can also happen. I love this picture because it shows our original anatomy, and then with removal of the prostate, what happens. In men, there are 2 areas for continence mechanism. The external sphincter down here is your primary mechanism. This complex here at the bladder neck is secondary. This bladder neck can be damaged during prostatectomy as the prostate is removed, and this area is then resewn down to the internal aspect of the urethra there. As men age, these muscles also tend to get lazy because the prostate's there to just block the pathway of urine out. So one of the modalities for treatment is going to be working on these muscle groups, and I'll talk about that in a second. But the last picture here to highlight, look at all these nerves, all right? So in the radiation setting, nerves can also be damaged. Again, prostatectomy, we talked about more of the internal nerves, but again, nerves and muscular complex externally. So what do? What's a great option is pelvic floor physical therapy. So this is not just, looking online and doing some Kegels. This is being proactive and going to see a pelvic floor physical therapist. Gosh, if I had my wish, I would send all prostate cancer patients to a pelvic floor physical therapist before surgery or radiation, and then fairly soon after to help with muscle recovery and potentially improvement of nerves. Now, this I was turned on to by a patient recently. ProAct, it's a new technology. I do not have any personal experience with it, but I wanted to highlight it. There are 2 balloons that are placed through the scrotum, small incisions, and then inflated alongside the urethra. All right, so the prostate was removed here. That's represented by our suture line. And these balloons are mimicking the presence of the prostate. They can be inflated to different sizes. And the hope is to help support this urethra and your external sphincter to keep men dry. So it's called PROACT. Again, I don't have personal experience with it, but it's out there. I encourage patients to try new technology. You know, it seems quite safe in the right hands. Stress incontinence is, again, something that we see in men post prostate cancer surgery. That's because, again, where you get transmission of the intra-abdominal pressure to the bladder, and there's not much resistance there, so urine will leak out. What this option for treatment is what's called a male sling. It's a piece of synthetic material that wraps around the base of the bladder, where the prostate and the urethra, where the prostate used to reside, to again help provide a little additional support. Artificial urinary sphincter. This actually works wonderfully well. All right. Again, this is another device similar in some technology to the implantable penile prosthesis. There's a pump within the scrotum that allows for activation and deactivation of this cuff. The cuff surrounds the urethra and essentially mechanically constricts and then allows for relaxation, for emptying the bladder. Another much smaller reservoir resides within the pelvis. Again, this can exist at the same time as an implantable penile prosthesis. One of the other things that I did not include here, and that is my apologies, is in post-radiation therapy. So what changes do we see there within the bladder? We see more effects of blood in the urine, significant blood in the urine, frequency and urgency. And that's because radiation is an irritant. It can irritate the bladder lining. Men in that situation still have the presence of the prostate, but because of the irritation of the bladder lining secondary to radiation, they will develop more frequent and urgent urination. That's treated on a different modality, typically with what's called our anticholinergics, so medications that will help relax the bladder. That can be taken orally, or injectable medications that go into the muscle of the bladder, something like a Botox that, maybe I would get to stop movement of my eyebrows, but as you can see, I definitely don't have that. That can be done within the office setting. Patients usually tolerate it quite well. You do have to be mindful of urinary flow after administration of Botox to make sure that patients are still able to empty their bladder. The same when you're taking any oral medication of that variety that's going to relax the bladder. You want to make sure that you are the flow is adequate and you're emptying well. So with that, I'm going to stop. Hopefully this has been a helpful and educational time for you. Hopefully they'll send out my email. If you have any questions, please let me know. I'm happy to answer them offline at a later date. But I applaud you all for being here. Again, I appreciate your time. I appreciate what you're doing to advocate for yourself and those who have battled and hopefully beaten prostate cancer, but have to face the quality of life changes that come afterwards.